Hi, it's Ms. Belial, and this is one of the video lectures for Emergent Unit 6 Summer. So let's get started. Ards. It's something that you need to know about. I'm not really sure if you're going to probably work with patients with Ards. It's considered a very emergent respiratory distress syndrome. But I do want you to be familiar because you might work in an ICU or you might work in an ER, somewhere like that. Plus, with everything going on with our pandemic and COVID-19, it is something that you see in patients. There's a little more going on with them, and we're finally figuring out this, that, and the other. But I do want you to be familiar with, okay? So as I talk to you about ARDS in this video lecture, I do want you, I will give you tidbits of areas to maybe review for the testing purposes. And so I just want you to listen to me carefully and we'll get this done. I know you're excited, it's almost over. Let's get started. So acute respiratory distress syndrome, or ARDS, is what it is. So if you hear that word, that's what it means. It's an acute, meaning new onset. It's not a chronic condition. It's an acute respiratory distress syndrome. They can have signs and symptoms: persistent hypoxia. That means they have a low oxygenation. They are not oxygenating. And the reason why is due to decreased pulmonary compliance. So the lungs, they fill up with edema fluid and they can't move. They become kind of hard. So you're pushing air into it and it's like, and then you try to push air back out and it just, because of the compliancy. So with doing that, it traps and creates all these issues, and you're not having the shift. So the body is not being able to move the air appropriately so that it can oxygenate. They're going to have difficulty breathing. And then this is the interesting, they're going to have non-cardiac bilateral pulmonary edema. So we can see pulmonary edema due to heart failure, cardiac issues, but this pulmonary edema is not that. This is caused by the non-compliance and everything that's going on in the lungs. And on x-ray, you're going to see dense pulmonary infiltrates. So this x-ray is not going to be a pretty x-ray. It's going to be quite interesting. And just a little tidbit, if you want to go on and if you're interested, you can just type in, dense pulmonary infiltrates on an x-ray, chest x-ray, and it will pull up and show you one. And so that kind of gives you an idea of what you're looking at. These are stages of edema formation in ARDS, and I like it. So the first A up there is a normal. That's your alveolus and your pulmonary capillary. Everything's looking great, right? Then we get to B, where we're going to have an increased flow of fluid into the interstitial space. Do you see how that's pinking, getting kind of pink around that? Well, we're filling that with fluid. So if I take anything that is, say I put a little probe down into a container and I start to add water, and is that going to create a little harder movement of anything in that container if I start to fill around the thing that's down in there? Yeah, it is. It's just like you're creating almost a blockage due to fluid. And then what happens is the edema occurs and the fluid will cross that blood-gas barrier, as you can see, and the whole thing just fills up. And when that happens, you're in ARDS and you're not going to be able to perfuse appropriately, okay? You cannot oxygenate. It's very difficult. Okay. These are some results. You're going to have severe difficulty breathing, dyspnea. You're going to be hypoxic. We've said that. You're going to have decreased lung compliance. The lungs are not going to want to move. They're just like, diffuse pulmonary infiltrates. We see that all over the x-ray. We look at that and we go, ooh, that doesn't look good. We have about 150,000 cases yearly. So, and then 25 to 40% mortality rate for these patients. Now, on the slides that you received from me originally that were posted, it said 50%. but in your book, it is updated 25 to 40%. So I did change that on my slide. You will not be tested on that percentage, but what I want you to understand that this kills people. So if they have multi-system issues, if they're having multi-system things going on and they go into Ards, a 40% chance of survival is not the greatest, is it? You're almost 50-50. And I wouldn't want to be there. Now, do people survive this? Yes, they do. Do they have issues? Yes, they can. So it is so important that we understand how to take care of them and how to help them get through this. And there's ways of tweaking ventilation on a ventilator with different things so that we can protect the lungs. They get that sticky hard and won't move and flow to the things that they should flow. And so it is so important that we understand our ventilator settings so that we don't force so much air through that we rupture the alveoli, right? Correct. We'll have a systemic inflammatory response is the common pathway. And the alveolar capillary membrane can become injured. So intrinsic causes, sepsis, shock. Extrinsic causes are aspiration or inhalation injuries, okay? And we'll talk a little more about those as we unfold different injuries in this emergent piece. But just understand that can cause that damage, injure the membrane. And when we injure that membrane, that's when we start to have all these issues. We'll start to have the edema, we can't breathe, we're in a hypoxic, severe difficulty breathing, those kind of issues. Okay, this is a great picture. This is proning. Turning a patient in prone position, that's flipping them on their stomach, right? We're taking a patient that's laying normally flat in the bed and we're gonna flip them over. When we do that and flip them on their stomachs, they will ventilate better. Now, one of the interesting things is I've proned a couple patients in ICU when I worked ICU. It is very difficult. A lot of these patients, one, they're intubated and ventilated. A lot of them might have chest tubes and other things. So you have to be very careful in moving them over with all of that equipment, right? So that we make sure we maintain everything, because this is a life-threatening issue. And we have to be very careful. We don't lose any medicines that are infusing through IVs, that we don't pull their ET tube out and then we have to re-intubate and all that. So it can be pretty tricky to prone a patient. It's interesting seeing it takes a lot of people. When we did it, we had a lot of chest tubes in this patient, the last one that I did, and it took about 8 of us total to flip this patient to make sure everything was protected and we were there. We got him over, ventilated much better, was able to oxygenate, and things improved. Now, I will say this, is if you've been watching the COVID-19 play out, proning is part of that for these really intensive care patients that are pretty critically ill. They are proning them and finding that that helps a whole lot. I just think that's an interesting to see. And remember your positions. So proning's on the stomach. This is great. This is you want to have them on specialty beds. This is a total care sport. This bed breaks down into a chair mode. So if you have a patient that is alert and oriented, that is able to sit up physically, like you can put them in a sitting position, but they're on a ventilator, and they don't necessarily have to be completely oriented, but say they're just a little groggy, but you want to get them in this upright position because, of course, everything's going to do much better, right? Diaphragm can go to where it needs to go, stomach, abdomen, all of that can fall downward, and then we open the capacity to breathe by sitting up. Okay, so this is a great picture. I have sat a lot of patients up in this mode on a bed that were very ill, but they had stable vital signs. That's the ticket. They had a stable blood pressure, they had stable heart rate, and we were able to sit them up, and they did much better on the ventilator. So just an FYI are there. Complications in treatment. You can have ventilator-associated pneumonia, right? VAP, You've heard VAP in the hospitals if you've been there. And that is something that the hospitals have really worked on trying to prevent. And the reason why is if a patient gets ventilator-associated pneumonia, it is just like a UTI from putting in a Foley catheter in a facility, then the hospital absorbs cost for this patient because it is something that happened on their watch. So we want to be very careful that we don't break the circuit. One of the biggest things that they realized is that we would break the circuit to go down and suction a patient. Or we would, and meaning breaking the circuit is we would detach the ventilator from the patient and kind of lay it over the vent. And then we would do whatever we needed to do. And then we would bag them, right? And then we would eventually take that off the vent. It's not touching anything, it's just dangling out there. And then we would reconnect. Well, what we realized by doing that and using different suction techniques and all that, that by breaking that system, we were creating VAP, ventilator-associated pneumonia. So we went to a system that's a closed system. Everything's attached. You suction a patient, it's right there. It goes down a sleeve and you pull it back out and everything kind of stays there. If you're in those situations, it's good to take a look, especially in ICUs if you have an opportunity. The other thing is mouth care. And I think sometimes as nurses, we forget that. That is a basic care and that should happen on all patients. But if you're on a ventilator with a big tube breathing for you, it dries the mouth, it irritates the mouth, will pocket a lot of saliva depending on what side. It can break down the tissue if we're not careful. So it is so important that we move the tube accordingly. You know, like we'll have it here for a day and then we can move it to the center. They have these little devices that hold on to the tube and we're able to move them from place to place to place so that we don't have continuous pressure, which causes a total breakdown in the mouth. We also need to move the tube so in the back of the tongue, the back of the throat, everything, so that we release that and relieve that pressure. Also, bacteria grows. If we have bacteria in the mouth and it's all attached to the lungs and we are putting a breath in and we're taking a breath out and from the ventilator, and then I take my own breath and breathe and it gives me a little support, and my mouth's full of all of this and it's trickling down all these places, I can get ventilator-acquired pneumonia from that. So it's so vitally important that we clean the mouth, that we do this mouth care every 2 hours, and that will help prevent it. Barotrauma. Barotrauma, I always think scuba. I did get a diving certification years ago. I haven't been diving in forever. But I think about it. It's decompression sickness if you think about it. You have an increased pressure in your lungs causing an air embolus. So if we're down low and we come up really fast, we can create barotrauma, right? And divers come up and then they pass out quickly and all this. The increased pressure can cause rupture, and then air penetrates into the tissue around the lungs. And when that happens, we get barotrauma. So it takes about 2 weeks for a mild to moderate case of barotrauma to resolve. It's not something that just and we're done. It takes a little bit of time. They can have shortness of breath, painful swallowing, hoarseness, and fullness of the neck. They, feel fullness of the neck. If it's really major and we have these issues, we can put them in a hyperbaric chamber. But a lot of people that have barotrauma can have just oxygen and just watch them, really observe, reassess, assess, reassess. I've said that a lot in simulation. And that's important. We can also put a chest tube in to help recompression. So that will help with that air and moving things. Volutrauma is lung injury secondary to over-distension of the alveoli. So if your alveoli really extend, it's kind of like starlings. What am I thinking? Starlings, there's something there. But you know how if you stretch the heart and it goes, I will think of it here in a minute. But anyway, you stretch it too far, it's like blowing up a balloon. If it's a brand new balloon, it's a cute little balloon. You blow it up and it gets big. But when you release the air out of the balloon goes back, but it never goes back to that small, right? We've overextended it and now it's all flabbity, right? And anything that's flabbity is not great at doing what it needs to do. If it started out like this and now it's like this, it's not going to work well. You're high risk for stress ulcers, so we will medicate accordingly to prevent ulcers. Matter of fact, anybody in ICU normally gets different medications to protect their stomach to prevent stress ulcers. And it's all prophylactic. We're doing it to prevent it. Now, it doesn't mean they have them, but we want to try to prevent them getting those. Because all you need is to have Ards and then have a GI bleed, right? You have a stress ulcer and it ruptures and you're bleeding and have to go to surgery and all that. And also renal failure. The kidneys will take a hit on this because we're not perfusing. Simple as that. We're not oxygenating stuff. So it doesn't, kidneys don't like it. They're like, So anyway, let's move on. So mechanical ventilation. I do not want you to memorize mechanical ventilation. I want you just to read through and kind of understand it. So that if you get involved in an area once you graduate nursing school or you go back and get your RN and you're in an ICU, that when you're dealing with mechanical ventilation, you're not just a deer in headlights. You're not just, you have kind of heard it and then it'll start to sink in for you. So modes of ventilation, we have pressure support ventilation, we have continuous positive airway pressure, and we have non-invasive positive ventilation. And what more or less that I want you to understand is that the different modes will do different things to help the patient breathe. And so by looking at chest x-rays, looking at ABGs, a physician can order different modes of ventilation and tweak different areas of that ventilation to help the patient oxygenate better so that we really get things going on. Dangers of the mechanical ventilation. We can create barotrauma with mechanical ventilation. So what happens is we can have an increase in that pressure of the lungs that causes an air embolus. So we have to be really careful that we don't create barotrauma. And we see that. If you don't have a doctor that really knows what they're doing, or they're not that, they've not been in that intensive world to make those decisions, you can see some issues happen with mechanical ventilation. Oxygen toxicity, it is a medication, don't forget that. It is an order, you have to have oxygen. You see it used freely a lot. We'll put nasal cannulas on, 2, 3 liters, 4 liters. You always need to call a physician and get an order for oxygen. If you have a patient that is having trouble breathing, the oxygen saturation is down on the monitor, please you can get a nasal cannula, have somebody page the physician while you're doing that and put them on a couple liters. It's not going to hurt to keep them oxygenating, but giving them oxygen while you're talking to the physician, and then the physician can make the decision to either continue with the nasal cannula or to give you something else. Impaired cardiac output. We can create issues. We can bottom out blood pressures with PEEP. And different things on the ventilator, fluid retention, gastric distension. If we're giving them too much and just forcing max air in, we can create their stomach, them to have gastric distension and can make them very uncomfortable and can cause a lot of problems. And gastrointestinal bleeding from ventilation. Stress on the body, doesn't like it. Okay. These are different control and settings. Tidal volume, rate, you would do the tidal volume. That's how much volume that is going in. Your rate, breaths per minute. Your FiO2 is the oxygen on the ventilator. So we look at an SaO2, that's your oxygen saturation on monitor. We look at a PaO2, that's your oxygen in blood on a blood gas, an arterial blood gas. And then we look at FiO2, and that's a fraction of inspired oxygen. So on my ventilator, I program how much per the physician order needs to be given to the patient. So some patients are on 40%, right? Some are on 50. Some might be on 80. It just depends on what's needed. But you got to be careful, the physician does with this, and something for the nurse to think about is if we give way too much, if they've got great stats, gases look great and everything, and we're giving them 90% oxygen on a ventilator, we can give them oxygen toxicity. We can create issues with them. PIP, CPAP, PEEP, and there's other settings out there. The ventilators today in 2020 are quite high tech and they can do great things. So things have really come a long way over the years. So it's a good thing. Okay. Nursing management. I say to you guys in simulation last semester or ones that came the beginning of the semester or whatever, and I'm going to say it to everybody in this little video lecture. You need to think about everything of what it is, and then as a nurse, what am I going to do? How I'm going to manage this patient, how I'm going to feed the patient, how I'm going to move the patient, how am I going to teach the patient, how am I going to teach the family of the patient, how am I going to treat the patient, you know, how many times I'm going to get the patient up, how's the patient going to void? As a nurse, what am I going to do to make sure that the patient is getting the best nursing management possible? So for these patients, we want to always assess the patient first and then the ventilator second. So we want to make sure that the tube is in place, the ET tube. We want to make sure that the patient has breath sounds on both sides in all lobes of the lungs. We want to make sure the chest is rising and falling and not asymmetrical stuff. We need to be coming up and down at the same time. We want to look at the trachea and make sure that it's in alignment and not shifted over. We want to look at the patient's response. If you have a ventilator on and you just look at your ventilator settings, write those down and go on about your business, never look at your patient, and then finally you look at your patient and he's got blue lips and, you know, he looks stressed trying to breathe on a ventilator, that's an issue that needs to be addressed. Something's going on. Is he in pain? Should he be sedated while he's on the ventilator? Is he supposed to be sedated on the ventilator? So you need to look at what's going on with the patient. Treat your patient first. Look at your patient. If you've got an abnormal heart rate going on and it doesn't look normal or whatever, and it's alarming at you, look at the monitor, but then assess your patient. Are they laying there all watching something on TV? Or are they, you know, they're not perfusing, their heart is getting really irritated and things can happen? Treat your patient. Start to think, what would you do? Well, first of all, I would check my ventilator to make sure I'm connected to everything. That's one of the things that happens is patients can turn and disconnect themselves from the ventilator. And even though they should alarm, sometimes it takes a few minutes for it to alarm. Or I had a patient one time rolled and their ventilator tube got caught in the side rail and it kind of crimped it. And when it crimped it, things flow better through something that looks like that than something that looks like that, right? So as it was crimped, they weren't getting the airflow, but it wasn't enough to make it alarm, but it made the patient go into distress because they were not getting the airflow that was needed. And then you would want to manage the ventilator system. You want to make sure that it's always plugged into a red outlet anywhere that you're working. Those are the emergency backup outlets. So if a power goes down, you've got a backup generator that will run the ventilator. Because if you don't have power, it doesn't work. One of the biggest fears I ever had is I worked in Savannah in CVICU and we had a big hurricane coming through. And one of the things we had to do was go through and make sure every ventilator, every kind of equipment, piece of equipment that needed to keep running no matter what was plugged into a red ventilator. And I actually have had a ventilator that was plugged in, this was in Tennessee, it was plugged into the red outlet and they checked the generators. And when it went down and the generator should have picked up, everybody else's ventilators came back up. But this one patient's, it didn't, it failed. The ventilator failed. And so we had to bag the patient, switch the ventilator. So if ever you're in a situation and you're dealing with that where you work, and they're going to do generator checks, which are usually done in the early morning hours on night shift, Go check all your ventilator patients once that happens. Make sure everybody's breathing okay and the ventilators are working. And try to prevent complications. What can we do? We can turn the patient. The patient should be turned frequently because we want to move edema, right? Anywhere edema is, we want to move the body because that helps that fluid shift and then the body can absorb. For the lungs, it helps things move and we ventilate better. We want to do the mouth care that's needed. We want to sit them up if we can. We want to do all of those things, give them the medications that are needed if they're having any issues. Tension pneumothorax, and we'll go into even a little more or discuss it into the trauma side of this, but a tension there's different pneumothoraxes. So you can have a tension pneumo, you can have a hemothorax where it's blood in there. You can just have different things, but a tension pneumo is what I'm going to talk about. You can have asymmetry of the thorax, tracheal movement away from the midline towards the unaffected side. So if I'm having a tension on my right side, my trachea is going to move from the midline towards my unaffected side. So if I'm having trouble on my right side, then my trachea is going to shift, right? It's going to go to the unaffected side. Respiratory distress, you need to be breathed with both lungs. Absence of breath sounds on one side. So when you listen to a patient with a tension pneumo, if it is big enough, if the lung is completely down, you won't hear breath sounds. Sometimes though, you can have partial tension pneumos. So just a part of the lung kind of pushes down. If that's the case, you're still going to hear some breath sounds, but they're going to be diminished compared to the side that's unaffected. Distended neck veins, cyanosis, and you're going to hear that hypertympanic. And what that means upon percussion is when you are percussing, it's air. You know, it's a different sound. So you're going to have more of a pitch. If ever you're in, when you're in doing your assessments right now in this third semester finishing up, do some percussion. It's good. The abdomen is the best. If you percuss on the abdomen, you know, put your fingers and percuss, you can really hear if it's fluid or air. If they have a stomach full of air, you'll hear that hypertympanic sound. With the tension pneumothorax, just FYI, it's the most common. And what happens is air will enter into the pleural cavity. So you got two lungs sitting here, and there's this pleural cavity, and air enters in through the trachea, through the lungs, into the pleural cavity. During inspiration, we pull the air in, breathing in, and the air goes out into the pleural space. Okay, so the air has come in. Now we need to get the air out of that pleural space. But with a tension pneumo, there's a little valve type thing, and the valve just doesn't work, and the air is out there. So it doesn't get back in and out of the body. It sits in this area. And then every breath a person takes that's having this tension, more air will start to build up. And then when you have that air built up, it causes pressure. And that pressure will cause the lung to deflate. It becomes small, and you can collapse an entire lung down to nothing. And they become hypoxic. They become in severe respiratory distress. You have to fix it. And the way to fix it is to get the air out of that, right? So the problem is that air is sitting in there, and we need to get it out. And what we can do is needle decompression. You can take a big needle. You're trained to do it. Up here, you say, I'm having the trouble over here. In between the ribs, over the top, a needle goes in, say that's just where, and you hear a and the lung will re-expand, and then the patient breathes. You can actually see someone in total respiratory distress. You put a needle in there, it goes, and voila. Sometimes we have to do chest tubes, just depending. And that ends this video on ARDS, and that's in a nutshell. Really quickly, I want to say this to you. Review your ABG, what's a normal PA, CO2, PaO2, what's your oxygen normal, what's your CO2 normal, what's your bicarb normal on a blood gas. That will help you with this test. The reading is very one page pretty much for Ards. There is not a lot to it. I do want to say that it is so important that you look at respiratory distress. What is the one thing that you think we would want to do? Let me stop sharing this for a second. There we go. What is the one thing that you would want, do you think we would want to check if we're having any kind of respiratory issue? Lolly? I'm just checking. ABGs. ABGs tell us what's going on. We know what our oxygen, real true arterial blood gases will give us real numbers of what's going on with breathing. So you need to think about that. If you get a scenario and this patient's having, you know, respiratory distress of any form, we're going to want to get an ABG. If we're working hard to breathe, there's something going on. People that are tachypnic, there's something going on and the body's trying to correct it. If there are people that are, they can't maintain an airway, they need an airway. And those who just kind of, and then no breath at all for a while, they are not breathing enough. And there's a reason, something's going on and we've got to fix that. And in the meantime, how do you assess it? You want to listen, look, but the main thing would be for any kind of respiratory issue, I'm going to say it one more time, an ABG is the key thing. It's going to break it down for you. You know what the body's pH is, you know what the body's oxygenation is, you know what the CO2 level is within the blood, and we know what the bicarbs, we know if they're in acidosis or alkalosis. And that is so important because that's how we will treat them accordingly. If you have a patient who is struggling, say that they come in and they can't talk. It's like me walking now. I've been trying to walk a lot. And I'll walk and up the hills. It's like, don't talk to me because I can't talk back. It's like, right? And so every time they go to talk to you, they've got to take a breath. It's like, or they'll talk and then they have to take a moment to catch their breath. If that is the case, what as a nurse would you want to do? Anybody in respiratory having trouble breathing, difficulty, what do you do if they can? You want to sit them up, right? Because what happens when we sit patients up or people up, clients up that are having difficulty breathing? The diaphragm relaxes, it opens up, and we can then expand and breathe better. If I'm all crumpled up in a chair or a bed, my breathing's going to be very my rib cage and my whole expansion of that is going to be kind of occluded or smashed, smushed, and then I'm not able to take that deep breath. So if I sit my patient up, pull my patient up in the bed, put them down and put a little nasal cannula on them to give them a little extra oxygen, they're going to breathe better. These are patients that are not crashing. They're just having trouble breathing. And you want to do this so you can prevent the crash. An ounce of prevention is worth a pound of cure. And that just goes all day long with emergency. Okay. I think I've covered everything with Ards that I would want you to know. Go ahead and read through your chapter. Don't get too lost in some of that. What I tell you in my lectures, I'm promising you, I am giving you information you need to read. I'm not saying not to, but the information is there for you. So you'll do great. So that's Ards in a nutshell. I hope you enjoy.